circulation, and a little bit of, no, I'm not doing that. Okay. Now, what we're going to do the final 2 weeks is we're missing next week. I'm going to combine next week's material with the week 9 and week 10 material because it's basically the same. Next week, I put this with pelvis and it talks about the pelvic circulation and through the organs, that sort of stuff. So those three reproductive organs are also in the pelvis. So we're just going to combine the two together. I think we'll talk about the blood supply to the abdominal organs. You got tons of blood. Y'all said it okay with me to turn some light. Let's turn some light. Sure. Let me turn this down. This damn thing. Turn it off. All these big bright fluorescent lights in the hard to see. There we go. I will turn that dark. All right, so we're going to talk about the abdominal circulation today. Now, this is kind of a continuation of what we did a couple 3 weeks ago, a month maybe. We talked about the thoracic aorta, or descending aorta. Now, the aorta descends through the diaphragm through an opening called the aortic hiatus. And at that point, you start referring to it as the abdominal aorta. Because descending aorta is not really specific enough. Descending aorta starts all the way up here, right? So it's not really specific enough. So you really want to make sure you talk about it and use abdominal aorta to be correct. So this is kind of an outline of what we're going to talk about. And I'm going to throw a little embryology in here this morning. So we have this inferior phrenic artery, supplying the diaphragm. Then we have the celiac trunk, superior and inferior mesenteric arteries, renal artery. The suprarenal artery, got a whole bunch of those. Gonadal artery. And then you're going to go down the trunk kind of into the pelvis. We'll talk about the pelvic circulation separately 2 weeks from today. But we do have the beginning of the pelvic circulation starting up in the abdomen. And in fact, the blood supply to the lower extremity actually comes from the abdominal aorta. So here we have some of the major branching. I'm going to add things in as we go. So here we have the diaphragm. Thoracic aorta, abdominal aorta. So we're going to have what's called the celiac trunk right there. The celiac trunk supplies the foregut. Talk about that some in your reading. Then we have the superior mesenteric artery right there. That supplies the midgut. And then finally down here we have the inferior mesenteric artery. That supplies the hindgut. And then common iliac arteries branch off of the abdominal aorta. This occurs in front of L4. And then this goes on down to the bottom pelvis and eventually the lower extremity.
Where's the inferior mesenteric?
Right here. Next picture, guys. All right, then we have these two gonadal arteries right here. Now, we're using the term gonadal because from this picture right here, we can't tell if this is in a man or a woman, can we? You'll see it didn't tell you, right? No reason to go for it. So if you don't know whether you're dealing with a male or a female, you refer to them as gonadal. If you know what gender you are dealing with, then you refer to them either ovarian or testicular. And I'm not even going to go there with anything other than that. Okay? So, hop down here now. And there's our superior mesenteric, inferior mesenteric, celiac trunk. Then we have the renal artery right here. Renal artery supplies the kidney. And we'll go a little bit with the renal stuff today. But the renal artery is what supplies your kidney. Now, your entire blood volume at rest passes through your kidney About once every 8 to 10 minutes. That's how much circulation you have going to the kidney. Then right here we have some arteries that are very important. The lumbar arteries. They supply the lumbar disc. The neural structures, spinal cord down to about L2, and below that you have the cauda and supplies the dura mater, the meninges, the dura mater covering the spinal cord. Now, this right here has a lot to do with you guys. Nobody really talks about this much. But all of you, y'all taking osteology, right? You're not Dr. Lunsford, right? And he's one of my students. So Dr. Lunsford talks about, I'm sure, degenerative joint disease, degenerative disc disease in the spine. When he was talking about the spine, all of you, have y'all watched your spines yet? Okay. Well, some of you have, some of you haven't. But if you look at those spines that are in the lab, you look at it around L3 or L4, some of them, maybe some L5. They got this little red thing sticking out. That's supposed to try to kind of mimic a disc herniation. Well, disc herniations happen, but they are not the be-all, end-all degenerative disc disease. In fact, at my age, I couldn't herniate a disc if I wanted to. I don't have the nucleus pulposus, the part of the disc is like a jelly donut. That's what the thing about a disc is jelly donut. So you got that little grape or blueberry or whatever inside of it. That's your nucleus pulposus. And that's what herniates out. You take one now, you have to go for drink. Very much filled it up for you. Got a little hole inside of it, right? So you sit on a table and squat, like you do when you're out. And some of that jelly squirts out through that hole. That's the disc herniation. However, the outer fibers is called the annulus fibrosa. And I guess you get that next quarter with Dr. McIntosh or Dr. Bill. So you will get that next quarter. But most of the time what happens is those fibers just get really weak. And so you don't necessarily have a herniation, you have a bulge. And then because of that, the surrounding osseous structures try to stabilize that by producing more bone. They're called spondylophytes or osteophytes. And what happens with that is it kind of grows around this bone, trying to stabilize it. Now the disc gets its nutrition through a process called inhibition. The discs are flexing and extending, just like this. And that's changing the pressure inside that intervertebral disc, making it a positive or a negative pressure. Whenever you have a subluxation or an injury to the disc, that process is compromised. And this right here becomes important. Because if you have these arteries, you are not getting proper nutrition to those discs. And then those discs start to deteriorate. And over time, they will completely disintegrate, gone. I don't have any discs in my lumbar spine below L2. Over time, they just degenerate. And that's degenerative disc disease. And you know this can happen irregardless of an injury. So everybody thinks, okay, you pick up something you have to do a lot of this. Not necessarily. Now, in my case, yeah, I don't think that way too many things. But a lot of times, it doesn't have anything to do with that. What happens are these lumbar arteries right here develop plaque called atherosclerosis. Y'all all heard of that. We have a covered head on. Just like you have in the coronary artery. And the coronary artery is because you have heart attack. Well, down here, because you're not getting proper nutrition to those discs, they cause degeneration of the disc.
These arteries innervate, like, the disc.
Yeah, absolutely. Well, they don't go in the disc themselves, they go into the bone and then they think of the cross, the implant of the disc into the bone through the process of inhibition. Is Dr. Lunsford about to talk about that?
Not very in depth.
The flexing, okay. And I'm walking around, I'm walking around right now. My lumbar discs are constantly having changes in pressure because I'm standing up now as opposed to sitting down or laying down. And what happens is those discs flex and extend, just like they don't come with lumbar field or I curve lumbar spine. So those discs flex and extend just like that. And that movement is pushing fluid from the vertebrae into the disc across that endplate of the vertebrae. Y'all look at vertebrae. I think he's got y'all doing some stuff in the lab. Y'all look at vertebrae, see how it kind of so it moves across there. Now, if that process doesn't take place, those discs do not get contrition, and then they break down. Or if that process is taking place, okay, it's fine. Yeah.
How do you prevent that from happening?
Well, I'm going to tell you right now.
All right.
The process is still taking place, but these arteries have been occluded from atherosclerosis by atherosclerosis. So that process is taking place, but you're not getting proper nutrition because you don't have proper blood supply. That part ain't a heck of a lot you can do about it. As we get older, I don't care how healthy your diet is. I don't care if you run a marathon a week. I don't care if you are vegan and run a marathon a week. You still at some point are going to develop atherosclerosis in your artery, especially us guys, because of testosterone causes. Guys are born actually streaking in their arteries. That actually from the beginning of atherosclerosis. We come out starting already in the home because of testosterone. Because testosterone is a fat-based energy. But you can prevent that by having proper spinal, or at least lessen that by having proper spinal motion. So if you had a subluxation at L3, that's affecting those zygapophyseal joints. So this is not flexing and extending like it's supposed to. Say it's misaligned physically. So that way it's not flexing and extending like it's supposed to, and that decreases that inhibition, which can accelerate the process. So the best way to prevent that is to have proper spinal alignment. Come see me on a regular basis. All right. Now you notice right here, we're talking about L1, 2, 3, and 4. You see anything about L5? All right. L5 comes from the pelvic circulation. We'll talk about that in 2 weeks. Median sacral artery right here supplies the sacrum. Are there, in my spine, are there discs in my sacrum? Yes, no, don't know. Didn't pay attention, I wasn't. Yeah, exactly right. In my spine, my disc have all disintegrated and the sacrum has fused, and it's supposed to. And the reason I'm saying me, some of y'all are, most of y'all are in your early 20s, and some of y'all may not have completely occurred yet. That happens in your late teens, early 20s. So some of this, especially you guys, it may not have necessarily occurred just yet. So, but we do have bone, we do have nerve, we do have dura mater. So that all still has to have blood supply, and thus the needs of the central artery. Now, right here, bifurcation. Bifurcation just means it swings. Right there in front of L4. How many of you had to look at the creek across the road this morning? You can. I got it. No reason to, unless it's jumping out of the river. But after it rains, when you see a creek, got a lot of different twists and turns. That's why I use that across the creek. It has a block twist and turns down a little. Every time it has a twist and turn. After a big rainstorm like we had more or less you see all this trash when a river changes direction. That's because the river water becomes more turbulent. And that's you may want to look at it right now, probably doing it. Has some swirling called turbulence. Right. And when you have that, all the trash, all the water bottles that people threw out their windows, and tires they filled with grease and whatnot, all get deposited right there where those major changes in direction. Same thing happens in the body. So every time you have a vessel making a major turn like that, you will deposit a lot of plaque. A lot of the cholesterol deposits, and then the body will deposit calcium to help try to prevent that from damaging the vessel above it. And you can see on X-ray, someone about 57, sometime my age, take a lateral lumbar film, you'll see the vertebrae. Then maybe half inch out from the vertebrae, you'll see a little white line. That's the plaque that's laid down right there. And everybody will have it. If you live long enough, you will have plaque because of the change in direction of the vessel. Now, can we do things to lessen that or prolong not having a problem? Oh, sure, thousands of it. But at some point, you will see that from just about everything. And someone in their mid-50s, that's considered an incidental finding. Nothing to make a big deal. I have seen the entire abdominal aorta calcified. I see him very often. But with that said, so we got this chunk of plaque right here, and all you see is the white line because it's the only place it's thick enough to show up in an X-ray most of the time. But it's going all the way around this vessel. And even a little bit down in the common impact. Would you want to take that patient, put them on their side, and in my case, drop 250 some odd pounds on them with a side posture, lumbar adjustment? Would you want to do that? No. No. Because you break that stuff loose and then it gets into circulation. And it finds those smaller arteries and will cause a problem. Cause a stroke or heart attack or that kind of stuff. All right, so those are the lumbar arteries. Now, more major branches. Let's see. I kind of did a little redo this morning about 5 o'clock. All right, so here we have our celiac trunk. We'll start with that. Celiac trunk supplies the organs of the foregut. You know, that was in your reading this week or last week, I can't remember. But it was in your reading about embryology. So the organs of the foregut, you have the stomach, you have the liver, you have the spleen, you have the pancreas. Anything that is supplied by the celiac trunk is how you delineate that as being in the foregut. So the celiac trunk makes 3 major branches. You have the splenic artery, the left gastric artery, and the common hepatic artery. Now, just above this, you have, this is actually called the inferior, that's probably, I just left phrenic in there, it's actually the inferior phrenic artery. You have the inferior phrenic artery. Supplies the top of the underside artery. You have the diaphragm. And you have some branches that come off of that, going to the adrenal gland, which is right there, called the superior suprarenal artery. Suprarenal is the proper name for the adrenal gland. And I got pictures of this here. What I've done is gone from simple to very, very detailed as we go through the presentation. So, let's hop down. All right, so now let's look up here at our celiac truncal arteries. Left gastric artery. That wraps around the lesser curvature of the stomach. Then you have the splenic artery. Splenic artery goes to spleen, right? It's called splenic artery. Then you have some smaller branches coming off the splenic artery called the pancreatic artery. There'll be a whole bunch of them. And you have it down here. Drop it down to the pancreas. The pancreas is right here underneath the splenic artery. And then the splenic artery gives us an artery going up the stomach as short gap. Goes very high. And then we have an artery called the gastro-omental artery coming off this splenic artery, going around the greater curvature of the stomach. Supplies the greater curvature of the stomach. And remember the greater omental. Yeah.
You said the splenic artery branches into the pancreatic artery.
The pancreatic artery is not covered. Yeah. So you have this gastro-omental artery going around the greater curvature of the stomach. And then it drops down and supplies the greater omentum as well. We talked about last week. Remember, we have got a tremendous blood supply. Yeah. It's on the neck. This is all in here. And if it's not here, see textbook. So you have the gastro-omental artery will also be referred to sometimes as the gastro-epipolic artery. So you'll see both names. And that's fine. And then over here on the right side, we have the common hepatic artery. Common hepatic, and I'll next slide I'll show it to you better. You got the right gastric artery coming off. And that makes a connection, what's called an end-to-end anastomosis with the left gastric artery. And they make their way around the top of the stomach, and they supply the lesser curvature of the stomach. And remember you have that lesser omentum? They also supply that as well. And then you have this artery dropping off right here called the gastroduodenum. Gastroduodenum drops down beside the duodenum, supplies the first and second parts of the duodenum. First and second parts of the duodenum are part of the foregut. Third and fourth part are part of the midgut because of the blood supply. So we will have this gastroduodenum. Now it will give you a right gastro-omental artery. And so what that does is come together with the left gastro-omental artery and makes an end-to-end anastomosis around the greater curvature of the stomach. Supplies the greater curvature of the stomach, supplies the greater omentum. Then makes its way on down around the pancreas. We'll talk about that shortly. Then we have the proper hepatic artery. And you know, that goes through the liver. Makes a left and right hepatic artery. And makes the cystic artery going over to the top. So let's hop ahead. All right, so here we have a chart showing everything I just talked about. And down here we have the picture showing everything I just talked about. Now I didn't mention this right here because this kind of varies a little bit right here in how it works. But you have an anterior and a posterior pancreaduodenal artery. Supplies the head of the pancreas. Supplies the first and second portions of the duodenal part of the duodenum. And so here we have continuing on down, showing that down here. And here we have our superior mesenteric. We'll talk about superior mesenteric in just a second. See right here everything. That's not the greatest picture. I can get a better picture of it in a second. But I wanted to put this bigger picture in each on this. Now we'll talk about the midgut. Midgut is supplied by the superior mesenteric artery. Now, you put this slide in here like this intentionally. Because up here, coming off of our common hepatic artery, we have the gastroduodenal artery, and then we have the anterior posterior superior pancreaduodenal artery, supplying the first and second portions of the duodenum. They are in the forehead. Coming off our superior mesenteric artery right here, we have the inferior pancreaduodenal artery. That supplies the third and fourth portions of the duodenum because they are in the midgut. So if you got a superior, then you have to have an inferior, right? You never even call it superior. And so this is where delineation of the small intestine takes place. Where the blood supply changes, right there. And that's going to happen between the second, about halfway down, not the whole second, but about halfway down the second. Now the superior mesenteric artery. A superior mesenteric artery is going to supply from the third portion of the duodenum all the way around about halfway across this transverse colon. So the superior mesenteric, remember we talked about that mesenteric peritoneum back a few weeks ago. You had the peritoneum hanging off the posterior abdominal wall, and you had that holding the mesenteric blade, and then you had the mesocolon peritoneum as well. So that's holding all this in place. Now, the superior mesenteric artery goes through the mesentery. That's held in place by the mesentery. And it makes, first off, the ileal and jejunal branches, right? They go over to the ileum and the jejunum. I'll show you how to tell them apart in just a second. But they supply the ileum to all the small intestine. Then you have the superior pancreas, or superior duodenal artery goes to the second, or third, and fourth portion. Then the superior mesenteric artery comes all the way down here and gives you what's called the iliocecal artery. Supplies the cecum, supplies the appendix, and the appendicular artery. Then we have the right colic artery, supplies the ascending colon. Then we have the middle colic artery. And this is where things get a little kind of varied from one person to the other. So middle colic artery supplies this area right here. Of course, the transverse colon has been reflected upward, so you can see this. Transverse colon normally hangs down like that, so you can't really see this one. Middle colic artery supplies this area right in here where the hepatic flexure is at. And it makes its way across the colon, across the transverse colon. Now, this is where things get a little different from one person to the other. In this case, it's showing the middle colon going all the way around like this, and that's just how this person is put together. But the middle colic artery generally stops kind of right in this area right here. And I'll show you in a minute. But in this case, it goes all the way around. I left that in there to point that out. If you want to see this, I have some anatomic images on Blackboard, and you're welcome to look at those anatomic images. If you can't access one, you know, I will straighten it out. But with them doing things a little differently with the new curriculum, I can't always. When I put something on it, doesn't help me see it. So you can't access it with it. But it's in your book. And that is all the structures of the midgut. Now we have the hindgut, the inferior mesenteric artery and its branches. So we have the superior mesenteric artery coming off right here. Gives you the sigmoid artery, got through it pretty well. Then we have the superior rectal artery, goes to the top of the rectum. Inferior rectal artery comes from the pelvic circulation, so we'll cover that in 2 weeks. But superior rectal artery goes right here to the top of the rectum. Then we have the left colic artery going over to the descending colon. And then we have what's called, this area right in here is referred to as the middle, the marginal portion of the left horizontal. And you can see how that goes across to their half the third way across the transverse. And that makes what's called the end-to-end anastomosis with the middle cold artery. And the only way you're going to be able to tell that is to just follow the artery and see where they go. And there's a nice little picture of this. It's kind of childish, but gives you an idea how the middle cold artery comes across and connects with the margin. Now, here we have a nice picture out of your textbook. Now, right here on the ilium and the jejunum, you can see how those arteries come across and go to the inferior structure. Now, up here in the jejunum, up here, you see how we've got these major branches that kind of make these little loops? Those called arterial arcades. And then from the arterial arcade, you have vessels actually going up to the tissue itself. Those are called the vasorecta. Now, up here in the jejunum, you can see you only kind of have one little layer of arcade, maybe the same. And the vasorecta are really long. Down here in the ilium, you see how you have multiple arcades in very short spaces. And that's how you can tell the two apart just by looking at them from the outside. And over here we've added in our appendicular arteries coming off our whole branch coming down here from our appendix in our system. And you can see how we got a nice picture of the circulation all the way around. So the real arteries. Yeah, we'll do that. Because in the second part of this, I don't want you all to look at your. Yes.
We go back just 1 second.
Sure.
We're talking about the arterial arteries, vasorectum. Is the vasorectum the arteries that are directly innervating the jejunum?
Absolutely.
And then the circle parts, it doesn't matter if they're
Those
long
are-
or short, those are all arcades. Okay. Thank you.
And I've got a little bit more detailed picture of that in a second. Actually, no, it was the last picture. All right. So here we are into the renal arteries. Renal arteries come off the abdominal aorta, kind of at the same level that's superior mesenteric. Superior mesenteric will vary a little bit exactly where it comes. But the renal arteries are more or less at the same level. They supply the kidney. Now at this point, I haven't really talked about vein tags. Don't say much about that. We got veins. But in the abdomen, you have two sets of veins. You have veins draining into the inferior vena cava. And then you have veins making up what's called the portal system. Now I'm going to switch slides. We're going to bring up the portal system. This is in your this week's material. It's a Word document at the bottom. Oh, here's time to let's take a break and we'll go to the top of it. It's better over done.
I was gonna say, yeah, I might need someone to introduce me to routine profession.
They do like a search there.
What'd you say to me?
Yeah. It's like over, right over the Chick-fil-A.
That way.
Yeah, across the street from Walmart.
Yes.
It's a shopping
I'm
I go visit City Hall. I don't understand. The best is you get like
so
it's
I'll tell you what though.
oh my god. I love the No, it is.
Let's go ahead and get started. Before we continue, I want to show y'all where the anatomized and the model videos are located. Okay, down here at the very bottom of the weekly lessons, there's a folder for anatomized videos and the model videos. They're all located in there. Now, the weekly things are not going to exactly line up perfectly because these are from the old curriculum. They're not going to exactly line up perfectly. but they're all labeled as to what they are. So all you gotta do is look at the heading and know exactly what you're looking at. And they're in here arranged according to midterm and final. And in fact, this actually lines up pretty close with your so everything is in there. It's all labeled. There are videos from the anatomage table, and there are also videos of actually one of my instructors going over the models. Dr. Ashipur, he has a little bit of an accent, so you may have to listen to it kind of slowly. Something a little harder. You can understand the things, you may have to just listen to it slowly and kind of take a minute with it. But everything is in there if you want to look at it. I'm not going to test you out of that. I'm still going to see you in the fourth quarter about that. But that is just there for some supplemental study.
Is this the final cumulative or is it
Yep.
post-it?
Absolutely cumulative. All right, so here is what we're going to do quickly. And there's signing good. Okay. All right, so before we continue, I'm going to put something up here from last week. And there is where I went over the difference in the blood supply last week between the jejunum and the ileum. And you can see how up here in the jejunum, you have, maybe 1 liter okay, not near as much as you have down here. Then you have the vasorectum going like this like that. And down here you have multiple layers of arteries, very short. And then you have very short arteries. And that is from last week's material. I just didn't see the need to put it in there twice. Okay, so this is where we left off. I kind of started mentioning a little bit about the veins. So we have the inferior vena cava. We talked about the inferior vena cava just a little bit when we were talking about the right atrium back behind the inferior vena cava drains into the right atrium. Inferior vena cava drains some of the structures you have and then lower extremity. But before we go any further, we have these renal veins right here draining the kidney. However, you can see right here, there's no celiac trunk or the superior mesenteric. You don't see any celiac vein right here, any superior mesenteric vein right there. The because they don't go into the inferior vena cava directly. So what we have is a third set of circulation at the venous in the abdomen for what's called the portal system. This is what drains the GI tract. This transports carbohydrates and protein from the GI tract to the liver. So we have going into the liver, we have the hepatic portal vein. And that's made up of the splenic vein and the superior mesenteric vein. Inferior mesenteric vein drains into the splenic vein. So the inferior mesenteric vein drains the same portion of the GI tract as the inferior mesenteric artery does. Two corresponding to one another. You get nice pictures of those in your textbook. And then we have the superior mesenteric vein doing the same thing. So it drains, the superior mesenteric vein is going to drain the small intestine. It's going to drain the right side of the large intestine. This is how protein and carbohydrates from the digestive tract make their way to the liver. They enter the liver, and everything is repackaged by the hepatocytes in the liver, and then makes its way out through what's called the hepatic vein. And that drains into the inferior vena cava. This picture's in your, it's just right, this is right below. I pulled it out separate intentionally. All right, so we got left gastric vein here. You may or may not have a right gastric vein. If you don't, that's fine. This is going over it because it's obvious. If you do, that's fine. If you don't, that's fine. Then you have this splenic vein. Now, food doesn't go through the spleen, does it? Talk about this last week. There's no food passes through the spleen. What does the spleen do? I see two or three things the spleen did last week. What's the spleen do? I get paid by the hour, guys. Like Senator Sterry, y'all going to stare at me?
Is it eating?
Does what?
Helps with the immune system.
Okay. The immunity, I'm sorry, this isn't what you were saying.
No, you're fine.
The 80s were too hard on
Not
me.
crazy accent.
The 80s were hard on me. In fact, we guys could understand what they were singing in music. I was talking to somebody the other day from New Jersey, and they didn't even know who the hell Bruce Springsteen was.
You're not investigating.
I've already failed. I mean, he's supposed to be the king of New Jersey. That's what I thought. So if y'all don't know, look it up.
Filtering blood, isn't it?
Do what?
The spleen filters blood.
Spleen filters the blood. So you have the red and white pulp. And I kind of left it at that because you can get a lot more about spleen from Dr. Hamden. So the spleen removes red blood cells, worn out red blood cells, and also helps, it has immune function as well. Gets rid of pathogens, parasites, viruses. In fact, it's one of the things when someone has a long-standing virus in the physical vein, you check for tenderness or maybe enlargement of the spleen. So the spleen should be about the size of this, right here underneath the very bottom of the ribs. So the reason this is part of the digestive system or digestive drainage to the liver is because of the red blood cells. So you're taking worn out red blood cells and sending them over to the liver. And they're made into what's called bilirubin. Bilirubin is a constituent of gallbladder, or bile in the gallbladder. And you secrete those in response to fatty foods. It emulsifies the bile salts, emulsifies the fat, breaks it up. And bilirubin coming from the red blood cells is part part of that. You also are recycling the heme or the iron before you go in the fat cycle. Now, this is what makes your poop brown. So if your poop isn't brown, you're having some sort of problem getting bilirubin from the spleen to the gallbladder. Now, what that is the whole gamut of things that can cause that. But if your poop isn't brown, that's why. In fact, it'll be what's been called clay colored stool. It looks like about like a pair of khaki pants or something like that. And so if your poop is like that on a regular basis, and you may need to go get some liver function tests or something.
It's not bilirubin? It's not bilirubin that makes it brown?
All right, so here we have the splenic vein coming in here as well. Now let's go back over here to our veins. All right, so we have our IVC. The hepatic vein drains into the superior vena cava, right up here just inferior to the diaphragm. Now let's step down here back to arteries. All right, so here we have our renal arteries. They make their way over to the kidney. Now we have renal veins as well. And the reason I put this in here, because I want to talk about the variations of renal material about your embryology. The kidneys, you have three kidneys that develop in succession. Okay, they deteriorate as you develop. The final set of kidneys are what you have right now. They're roughly right about. So the other two sets of kidneys will develop. They'll come online for a couple of weeks. Then they disintegrate. But sometimes the arteries don't. And so you have these what are called accessory pole arteries. Right? Those are just remnants from the previous sets of kidneys. They you may or may not have them. Nobody ever knows. You open up your abdomen and look and see. But I did want to mention those. Now, right up here, we have our kidney. What's on top of the kidney, we have our adrenal glands. And we're going to talk about this, the circulation to the actual adrenals here in just a minute, because it has a bunch of blood. But I also want you to note right here, okay, here we have the suprarenal vein right there, draining into the renal. Now over here on the left side, we have a little bit of a different pattern as well. Remember up here, we looked at our, way back up here, we looked at our gonadal arteries coming off the abdominal aorta. The gonadal veins don't follow that same pattern. So you have the left gonadal vein draining into the renal vein. The right gonadal vein is not really labeled, and I'll show you in a second. But the right gonadal vein drains directly into the IVC. That's because the IVC is slightly right center in the abdomen. So more veins you have across the go, especially the smaller ones, more likely they are to become occluded by the abdominal vessel. So that's why this gonadal vein on the left. All right, so renal arteries. I know we haven't really talked about the kidney anatomy yet, but we will do it. So we have right here. This is the cross section of the kidney. This is called the renal pelvis. This is called the major calyces. This is the minor calyces. Now inside the kidney, we have these functions called nephron. There's about 1 million of them. And they're arranged throughout this portion of the kidney right here is called the cortex. This is called the in the medulla, you have these triangle shapes called the renal pyramid. And then separating the real pyramids, you have the columns of Bartolome, or you use Burton as columns. But what happens is this kind of segments the kidney into different lobes. So you have what are called interlobar arteries, and they make their way up through the renal column and surround the pyramid. And they form what are called arcular arteries right here. So surrounding the pyramid, you have the lobar artery, and you have the little branches going down to that. Just think of triangle, seven that's right. We'll talk about it. Back to the top of the kidney, the adrenal. Adrenal glands have tons of blood supply. Adrenal glands produce epinephrine, norepinephrine, cortisol, sex hormones, and a few other little weird little things here and there. Not necessarily all the time. So you have this, all this blood supply going to the kidneys, or the adrenal glands, like you have in blood, right? So coming off artery right up here, you have a little collection of arteries called the superior suprarenal artery. And then over here, coming directly off the aorta, right above the renal arteries, you'll have the middle suprarenal artery. And then finally, coming off the renal artery, you have our inferior suprarenal artery. So you got three arteries, but you only have one vein. You have the suprarenal vein going into the renal vein on the left, and on the right, a lot of times we go directly to the IVC because here again, the IVC is slightly to the right center of the abdomen. Okay, if you're looking in the abdominal cavity, you look at the abdomen. The IVC actually includes the right suprarenal vein, unless you pull it out of the way. It actually includes most of the right kidney. There's just a picture of just the arteries by themselves. Okay, so natal and testicular arteries. Ovarian. So here we have the right and the left gonadal arteries. Usually come off right between the superior and inferior mesenteric. Now I keep telling you it kind of varies. It varies quite a bit. A lot of times you'll have the superior mesenteric artery come off with how we have here. So if it does, how it is. So if you see 5 different pictures, you may see five slightly different. Okay. But now we're back to our initial picture that I showed you on the abdominal aorta. And now I'm showing you everything encompassed. Okay. So the blood vessels going to the testes. You have what's called the spermatic cord. We'll cover that. Maybe do a male before we come. So inside the spermatic cord, you have nerves. You have muscles in the spermatic cord. Now, ladies, we're not leaving you out. You got so much stuff to do. The guys not just called spermatic cord. You hold the testes in place. But you also have arteries making their way down from the testicular artery up in the abdominal wall. And that supplies what's called the epidermis right here, and supplies the actual testicle itself. Now also in this spermatic cord you have venous drains, or what's called the panteniform plexus. You notice how you got one artery come down and artery just come more. Okay? Now notice the veins right here, kind of spread out everywhere. A eventually they come together, right up here at the inguinal canal. It's all descends to the inguinal canal. We talked about it a couple weeks ago. So it descends to the inguinal canal, and all comes together to make the testicular vein. And the reason you have this plexus is right down here. These structures right here are called the seminiferous skin. That's where the sperm are born. Now, around these seminiferous tubules, you have what are called liagen cells. They make testosterone. And so testosterone is then picked up by this antenniform plexus and transmitted back up through the testicular vein back up into the circulatory system. And that's how testosterone, most of the testosterone in the body, makes its way out of the circulatory system. A tiny amount of it comes from the adrenal. So actually it comes through the suprarenal vein. And yeah,
What's the difference between the three and two?
it just depends on how well it's combined with. And I'm not an endocrinologist. Total is what you need to be more concerned about. Free is what's there available to actually bind with receptors that produce X, Y, or Z. And y'all have plenty right now at your age. Y'all's free testosterone is probably in the 18. So you got so that goes back up there and makes the testicular vein. We're going to go into this more detail in a minute. Now, the somatic cord, since I mentioned that, has a muscle called the cremaster muscle. And that is an involuntary muscle. I'm going to regret telling you this. But the cremaster muscle elevates the testicles. Yeah, exactly. Brings it up. But remember, the testicles are outside the body. They're swinging around in the brain. Which nowadays we all wear pants, so who cares, right? No big deal. But say, I don't know, 5,000 years ago, you didn't. And you're running around the jungle. Now you don't want to snag the testicle on the fire, do you? Yeah, exactly. You later are going to cringe and thinking about that. So when you're in a stressful situation, it will elevate the testicle up against the bottom of the hair. And that's what it does with the master. It'll do in response to cold. It will do in response to fear or stress. But you also have what's called a cremaster reflex. But L1 superficial reflex. All how you had your reflex checked with somebody tapped your L10 leg. Well, you have the same thing with the cremaster. It's L1 superficial reflex. So what you do is you stroke the skin on the inside of the thigh way up here. And it will cause the testicle to elevate on that side. Now here is what I'm going to probably shouldn't go through. Because I actually shouldn't name it to be funny. But you can't do this to yourself. So guys, don't go to the bathroom and start rubbing inside your thigh. You can't do it to yourself. If I had said that, there'd be at least one of them down there in an hour or so. Because it's like a tickle treat. And you can't tickle yourself, right? So you have to have somebody else do this. And I'll let y'all work that out yourself. So I'll let you all work that out. You ladies don't really have a cremaster reflex, but you will. We'll talk about it. We're talking about female. You do have a reflex that you will sort of have. You'll study this in I don't know when y'all are doing neuroanatomy or clinical anatomy, but you will learn this. Talk about it then. They use it with folks who are quadriplegic and paraplegic to see how much function, if any, they have. So this is one of those you can't. Some people, they don't want to have a reflex. They can kind of use it. And you got several others like that. This is one, if it's working, you can't stop it. But that's cremaster muscle. We'll go into that more detail in a couple of weeks. So we have what's called the tunica albuginea, which is segmenting the testicle right here and separating all of these what are called seminiferous tubules into different parts. And that's where traumatic devastation. I keep forgetting you all haven't had embryology yet. So we're going to talk about the embryology of that. All right, so here is the course of the testicular artery. You also get a little branch coming down from the internal iliac. And here's the veins. So you can see you also have a little bit of, sometimes you send a little branch over here to the internal iliac vein. But there's the comparison I was pointing out earlier. Left side goes to the renal vein, right side goes to the abdomen. Ovarian artery. Now the ovarian artery supplies a whole lot more than just the testicular artery. The testicular artery supplies testicle. That's represented. Ovarian artery actually helps supply the ovary as well as the uterus. There's a lot more internal to the testicle. So we have this ovarian artery making its way down. Ovaries here, uterus here. Now we also have a branch coming off of the internal iliac artery coming over there too. Now this is a very juvenile, kindergarten picture right now. But here we have things how they get a little bit more detailed. So we have what's called the suspensory ligament of the uterus. Holds everything up. When you hear about women having trouble with their uterus sagging down, especially postpartum, this ligament, amongst a couple others, are what are not working. It doesn't hold the uterus where it's supposed to be. The uterus kind of sag for a long time. But you have the ovarian artery. Makes its way over here to the other. Now down here coming off the internal iliac artery, you have a uterine artery coming in. The two come together to make this big arterial vein, supplying both the ovary and the uterus. The uterus has a ton of blood supply. I mean, I don't think anybody doesn't know that. You ladies have a menses once a month. That's obviously blood that whenever you are pregnant, you gotta have tons of blood supply to the baby. So the uterus has tons of blood. And so this ovarian artery kind of comes in here and makes a big plexus with them. And the two of them come together and make this arcuate artery right here. And then, of course, the uterine artery makes up a part of that arcuate artery as well. And then you have just, we're going to talk about this again in a couple of weeks, just to be complete, you have a valuable artery. And there's a little closer picture of this. Don't worry about all these, how things are. That's going to come. Don't worry about it. That's part of the peritoneum. But you want to look it up. So here is the course of our ovarian artery. Now, the rest of the veins in the abdominal cavity. So not only do we have inferior vena cava, we have our renal veins. We have our adrenal or suprarenal veins. We have inferior phrenic veins here. Here we have the hepatic vein. That drains from the liver into the IVC. So everything that came up through the portal system and was kind of reprocessed, made into whatever it needs to be, drains into the circulatory system right here at the hepatic vein. And then down here, as you go down, remember we had our lumbar, well we have our lumbar veins corresponding to that as well. Now we have our median sacral artery. Now here again you can see how this is kind of right of center. So the median sacral vein actually drains into the left common. Doesn't drain into the right. And then we have an internal external iliac. We'll talk about that. All right. And this just shows everything together. Now I said something a few minutes ago about the portal system. Now someone say who was awake and not looking at Facebook. So what does the portal system do?
Drain blood. Not drain blood, takes blood to the heart, from the liver, to the heart.
Okay, both of you are about half. Okay, portal system drains the part of the GI tract, takes to the liver, and then makes it back to the heart. But what nutrients does it drain from the GI tract? Carbohydrates and proteins. Did I say anything about that? Okay. Well, I did sort of, but it's been a few weeks ago. Remember the thoracic duct in the back of the mediastinum? Thoracic duct is part of what system? Somebody asked me to go to the final exam for you. Lymphatic system. So the fat makes its way from the GI tract via the lymphatic. And it ends up in the thoracic duct. Thoracic duct, remember, empties into the complete lymphatic. I couldn't even tell like no record. So that's how the fat gets into the circulatory system. So at that point, it's not been packaged in anything, right? So what happens is the fat also makes its way through the liver via the arterial supply to the liver. So all this fat is coming up through that common and improper hepatic artery. And inside the sinusoid of the liver, it mixes with the blood that's coming from the portals. And then everything is packaged by the hepatocytes. I don't know how much detail Dr. Hoffman's going to go into with the hepatocytes. I don't do a lot with it because it's just not feasible. Because you spend a lot on the hepatocytes. So the fat makes its way back into the circulatory system. Right here. And that's all part of your renal. Lymphatic fluid is kind of a whitish. That's in part why it's because of fat and because of the white blood cells. Now, right up here, you have some lymph. I haven't made a big deal about lymph nodes yet. I mentioned them back when we talked about the respiratory system. You have the bronchotracheal lymph node. Node cleans up the stuff you're breathing in. Well, anywhere you've got something from the outside coming from the inside, you're going to have lymph nodes. Your appendix is just a big lymph node. Right up here, you have what are called the pelivic. Right there at the side where it's lymphatic duct drains into the pelivic duct. Now, if there's something really nasty comes into your body, most of the time it's going to come through your mouth, right? So you have lymphatic organs in the GI tract. They're called iron patches. But there's also some immune function associated with this as well. So especially if you have something in the large intestine, before pathogen, including cancer, these lymph nodes up here will pick up those bad cells, and they will become inflamed. And if you have a cancer in the abdomen, these nodes will become really hard. It'll be like a rock under the skin. They're pretty size. They're going to be the size of a good sized sweet pea. that is what's called pathognomonic or abdominal malaise. So you got those nodes and they're hard, and there's a couple of things. But I mean, you've got something very serious going on. Down you've got lumbar veins. Lumbar veins come off the IVC. All right, so the inferior vein cava is made up of the common iliac. Common iliac veins drain the pelvis, the internal. So if you have some sort of cancer or some sort of pathology in the pelvis, it can and will end up eventually in the IVC and potentially in the lumbar spine. Joe Biden got diagnosed with prostate cancer. And they're saying it's already involved in the bone. It's involved in his lumbar spine. I don't have to see an X-ray on it if I don't, it's what I know of. Because that's what prostate cancer does. And to a lesser degree, so does uterine throat cancer. Now, guy my age comes in the office, doesn't know, got low back pain, doesn't know why, didn't hurt himself, it's all of a sudden started, got a pain on the pain. Don't know why, didn't do anything out of the ordinary. Now, first thing you're gonna think is gender dysphoria. It's gonna be 90% of the time. But you better ask the guy how the urinary habits are. One of the first symptoms of prostate cancer is difficulty urinating. If you got difficulty urinating, you better get a simple blood test called prostate PSA. We'll talk about it. But if he has an enlarged prostate, he very well could have prostate cancer. And prostate cancer metastasizes to the lumbar spine. They were saying him was very advanced. I don't see how in the hell he could be at stage 9 or he metastasize to the lumbar spine and not have known about it prior to this. Because this guy, I mean, he gets a big physical exam and blood work every other week in the president. I don't see how this happened. I'm guessing last physical was sometime probably in November. Or left off like get everything free. So I would. So I don't know how that happened in 6 months time. Maybe it did. Maybe whoever was reading the book or didn't know how to read the book. I don't know how it was. Yeah.
Is it true, the prostate cancer, that a lot of people say they'll be sleeping at night and then they wake up and think they have to go, and then you get to the bathroom and you just can't, and that's where it starts, and then you get the lumbar and you're like, what's
That's usually your first symptom. Difficulty urinating.
So what is that waking you up at night saying, I gotta go to the bathroom and you can't go?
We're actually going to talk about that next week. I'll mention it. Okay, you have what's called the intrusive reflex. In the bladder, you have a muscle called the intrusive muscle that makes up the bladder. As that bladder stretches, you get to a point, you get 250 milliliters of urine. And then it starts signaling your brain, your hypothalamus, that, okay, we need to start looking for a place to pee. So in fact, he actually needs to pee. Because that bladder has started stretching and started filling. But because the urethra, to pee out of, passes to the prostate. Prostate's in water. Prostate is encapsulated. So when it enlarges hypertrophy, it has to go inward, not out. So what it does is compress the urethra. And so that guy doesn't have the ability to pee. Now, as that bladder keeps on filling up, the more you stretch into the intrusive muscle, the harder it contracts. So as the bladder continues to fill up, eventually gets to the point that the intrusive muscle will contract hard enough to force the urine past the obstruction in the prostate. And he can pee. But here's the kicker. Say he gets, now I'm just pulling numbers out of my head right now. Say he gets up 500 milliliters. So he'll pee. And then, I don't know, as soon as he drains the bladder down to, maybe 200 milliliters, he doesn't have enough pressure to force the urine passage structure. So he can't completely empty his bladder. And so the whole thing starts all over. And so he'll fill up, he gets nothing in the push of urine. And then doesn't move his bladder. So the second part of that equation is frequent urination. And also generally a weak strength. And you guys know what I'm talking about. You know how it comes out. It'll be dribbles and drabs, it'll stop and start, stuff like that.
So what is tubes?
I guess, if that's the one I'm thinking about, it's probably the one that causes the prostate disease. There are some natural homeopathic remedies for this. Saw Paul Benton works very well. I think that's the one that causes you to be able to feed. There's two or three different. But what it does is help shrink the prostate. And prostate cancer treatment, what they're doing is trying to shrink the prostate. Now, all of you guys, if you live long enough, you will have some degree of prostate cancer. If you live long enough. A lot of things will affect that. But eventually you will have some degree of this prostate cancer, and I'll explain why that is. Testosterone, they talked about giving him androgen therapy, plumbing testosterone. And he got whatever he paid, something whatever. I doubt he's making much testosterone. I doubt he is. But they actually will blunt the effect of that testosterone. And some of it, they will actually, sometimes they will give guys estrogen. They use more, I think they used to in the old days, now they have a little more specific things that like to block testosterone. I think it's specific enough to block it from the prostate. Because that is the number one thing, that's why, all right, so we take a serum testosterone test. And y'all walk over here with this work on. Y'all's testosterone level's going to be, 800, 900, 1,000, maybe more higher somewhere. Mine's going to be 250. And that's going to, as you get older, testosterone levels drop off. And that's one of the reasons why. Because every one of you with the prostate. At least prostatic hypertrophy. Same thing you ladies already need to do. That's why, as you go through menopause, if you didn't have menopause, you would always have a cervical and uterine breast cancer. Because those tissues, the longer they work to grow, and I'm going to talk about why they do, more likely they are to have a hiccup. And so, you talk to women who've gone through, obviously, so you talk to women who've gone through menopause, they have a lot of different symptoms, very valuable symptoms. Breast size will generally change. Big or small all the time. Because of the decreased estrogen. Now, we really want to get off on the track, so let's finish it. Alright, so here's a picture of our arterial supply here. Number 5, I put this in here because it comes off that middle segment. Does it come off? Yeah. And here's our veins. And that's it. And that's it. That's back on